Good afternoon, everyone. Welcome to day 3 of our Caraconference 2023, brought to you by Caracol, which is Greater Cincinnati's AIDS service organization devoted to positively changing lives in the fight against HIV/AIDS. I am Midge Hines, Chief Program Officer at Caracol. For today's session, we will have a panel discussion about systemic barriers to ending the HIV epidemic. We're really happy to have Jaziel Chapman, Hamilton County Public Health's HIV STI Program Coordinator for Ending the HIV Epidemic Initiative. So Jaziel, I will pass it over to you.
Thank you so much, Midge. So happy to be here with all of you today and excited to have this conversation. So before we get started, I'm going to have each of the panelists introduce themselves if they wouldn't mind. And I'm just going to go off the list. Linda Rose Franks, would you introduce yourself, please?
Hi, good afternoon. I'm Linda Frank. I'm a professor of public health at the University of Pittsburgh. I'm the PI for the Mid-Atlantic AETC. I've been working in the HIV epidemic since 1988. Prior to that, I worked in psychiatry, in substance use, and psychiatric services. I run an MPH program at the School of Public Health, and I'm very happy to be here today.
Thank you so much. Happy to have you here with us. Next up, Ricardo Martinez.
Hi, everybody. My name is Ricardo Martinez. I use he, him pronouns. I am the Chief Executive Officer for Equality Texas. I've been doing LGBTQ-centered work for a very long time at this point, but primarily in states like New York, Arizona, and now Texas. I'm happy to be here. Equality Texas is the largest statewide organization that champions LGBTQ equality in the Lone Star State, focused primarily around advocacy. But we do support a network of about 250 organizations, which include incredible direct service organizations that are working directly with our constituents to help contribute to the eradication of this disease. So happy to be here and looking forward to learning from the rest of the panelists and seeing what people have questions about.
Thank you so much, Ricardo. So glad to have you here with us. And our last panelist, Timothy Jackson.
Hey, good afternoon, everyone. Timothy Jackson, pronouns he, him, and I am the Senior Director of Policy and Advocacy at AIDS Foundation Chicago. More importantly, I'm a person living with HIV for nearly 14 years next month. And so that really centers and grounds my work as our lead state government lobbyist and policy professional, working on all of our policy priorities from bill ideation to bill implementation, everything ranging from LGBTQ rights, obviously people living with or vulnerable to HIV, healthcare, health insurance, just a range of different issues that we work on. And so AFC has kind of been in this fight for almost 40 years, and we primarily center on prevention, care, policy and advocacy, as well as housing. And so I am so grateful to be invited and share space with all of you all.
Thank you so much. So glad to have you here with us. So the first question I have, I'm going to ask you first, Ricardo. What local or state governmental barriers, if any, are you experiencing related to your EHE goals?
Oh, we don't have enough time to go into every single one of these, but I will say, I'll give you some landscape for folks who are just joining us. Texas is very unique in that, number one, we're a large state, right? And within this large state, we cover a tremendous amount of territory, a lot of ginormous cities, but we don't necessarily have a tremendous amount of support from our institutions. We don't have institutional power. So we don't have supportive governor. We don't have a supportive lieutenant governor. The 27 statewide elected officials are all Republicans. Not that that means that folks wouldn't be supportive of LGBTQ folks, but these folks have proven to have clear animus against our community. So that is barrier number one, right? The lack of willingness to help and see us, understand our experiences, and then prioritize solutions to what we're experiencing. And that trickles down to some of the symptoms that impact us, primarily communities of color, Black and Brown people, Black and Brown queer people. So healthcare and testing access, I think, is one of the main barriers. I think we are, because of this hostile landscape towards trans and gender expansive people and non-binary people, we are creating, we're pushing doctors who have multi-disciplinary expertise out of Texas and creating healthcare deserts for people that need solutions, that need access to care. So I think healthcare and testing access, because of these healthcare deserts, is one of the greatest challenges. Education that is available in various languages and is provided by people with lived experience is another challenge. We have a large Latinx, Latine population that is growing across the South. And we account for 73.8 of the HIV cases amongst U.S. Hispanics in 2021, right? And then knowledge of status, some people just don't access testing, period, right? And that might be a product of the education that we are not providing or making accessible to people in various languages. And so there is a percentage of people with HIV who have received the diagnosis and maybe have not sought care or have not even tested. And so, all of those things lead to stigma. If you think about in Texas, just the legislative landscape and the 141 anti-LGBTQ bills that were filed, which is a record for the most anti-LGBTQ bills filed for any state legislature in the history of the United States. I think you understand just the attack that we're under, the efforts to cut funding, all these healthcare bans. And I think I'll leave the other one to a question that is more related later on.
Thank you for that. You said a term that, if I may borrow from you, healthcare desert. A lot of times, we hear food deserts, but I never thought of the term healthcare desert, where so many people do not have access to healthcare. So I love that term. Thank you for that. Linda or Timothy, did you either of you wanted to add something?
Yeah, I would just add, I think that Ricardo is spot on with all of those. While not to the degree, obviously, in Texas, where I am here in Illinois, but some of the things that we are encountering are we've been able to get additional funding for HIV and LGBTQ organizations across the state through the General Assembly. However, because of vacancies at the State Department of Public Health, whether that's through ADAP or whether that is through just general people or investigators, all of the things, we've run into large numbers of vacancies. And so that obviously stands in the way of getting the work done. And so that is a huge barrier. Another barrier is, how do we increase access to PrEP and PEP, specifically among Black and Latinx communities? And so it's trying some different things. We were able to pass legislation last year that allows pharmacists to administer and dispense PrEP. And so we are doing the implementation work of that, but that's still not going to be good enough, to be completely honest with you, because you talk about food deserts and healthcare deserts. There's such thing as pharmacy deserts too. And so that's not even a one size fits all kind of fixing. So how can we really be nimble in addressing all of the different barriers? There are many more. We could literally be on here for the rest of the day and probably tomorrow too, talking about the barriers to ending the HIV epidemic. One thing I will close is, when we talk about the federal EHE plan, only Cook County receives funding from the federal government specifically for the federal EHE. Is the only EHE jurisdiction in the state of Illinois. There are 101 other counties in the state. And so how do we, yes, Cook County is important, that's where Chicago is, but how do we address HIV in those other 101 counties too? Because they're just as important. And so there are people living with and vulnerable to HIV in those counties, and how do we address that in a meaningful way too?
So thank you. So that brings up another question: how or what resources are being provided to those individuals in the other counties?
Yeah, one of the things that we try to do on a state level, obviously, if the federal government says this is supposed to go one place, it needs to go to that place. And so what we try to do on the statewide level is try to look at areas across the state that have high prevalence and incidence rates of HIV, whether that's East St. Louis, whether that's Rockford, Champaign-Urbana, Peoria, all of these places have high numbers, obviously not to the level of Chicago. But we want to again address those areas, and so and when you start addressing smaller jurisdictions, they tend to have more issues too, because again, you run into places where there may not be pharmacies. The doctors are spread far and wide, so there may not be on every other corner like they may be in Chicago, and so they present their own kind of list of barriers too.
Absolutely. Thank you so much for that. So my next question, Linda Rose, I will ask you, what kind of support have you or are receiving from local or state governments related to the EHE goals?
Yeah, I think one of the things that I think is most important, my ATC covers 5 states and DC, but I do public policy nationally with AIDS United. And one of the things that I think we have to think about is the coordination of the money that's coming into states. There's a lot of money on the table. There's substance use money, there's mental health money, there's HIV money, there's, maternal and child money. We have to figure out a way in which we can connect the dots so that we can coordinate the money that's coming into states and work together. And this is the importance of the HIV planning groups in states. And I would encourage people that we've got to get our HIV planning groups to think about that. And so when I think about barriers, I often don't like to talk about barriers because I like to talk about what can we do? What are the solutions? And I came up with this alliteration that I think for me describes what we need to do, and that are focus on services, supports, stigma, spending, and social networks. And I have a slide for that they can post if you want to pull it up or not. Doesn't matter, but you can make it available. But in terms of services, I think we've already talked about the problem of the fact that we don't have all the services, skip that, services that we need. Can we go on to the next one? This is what our, and one of the things that we need to think about is how do we get services in places where we need to have them, where people are and where people go. And we've already talked about deserts of healthcare providers. And so I think that, we need to get nurse practitioners and PAs to be able to prescribe PrEP. In some states, they can do that. In some states, they can't. And we got to fix that because there's never going to be enough physicians. The other thing that in our region, West Virginia gets no EHE money. We've had 3 outbreaks in West Virginia around the social networks of people sharing needles. And that's been a problem. And my understanding from listening to Harold Phillips at the White House, EHE is a health equity initiative because it's focused on areas of the country that have the highest rates of HIV infection. And that's why there's a lot of rural places that don't get any money. That's why West Virginia doesn't get any money. But there are ways in which we can use other resources if we work with our our HPGs and our state governments. The other thing that I think somebody mentioned is stigma. We have to have stigma as part of staff orientation, and it has to be ongoing. And it can't be just putting up a bunch of PowerPoint slides, death by PowerPoint. That's not how you get people to change their view about substance use, mental illness, HIV. There's got to be real values clarification, and we have to debunk some of the myths. And some of the myths are that, substance use is untreatable. Psychiatric illness is untreatable. HIV, this is a myth. All of these disorders are treatable. And there are people out there, and there are providers, and people, general public, think you can't treat people with substance use. And that is not true. The other thing that I want to mention are supports. We need an educational model for family and partners, because they need to know about what the treatments are just as well as the person who's getting treatment. And we need, of course, access to qualified mental health and substance use services. And we need to use more peer educators and navigators. And I think a lot of the states are spending money on these things. And they work. We know they work. I've been around since 1988 working in HIV when we had the buddy program for people with AIDS. And those buddy programs were just to help people to get to their appointments because they were dying. We know that works, and we know that it's working now. And then spending, we need services cost money. So everybody has got to be advocating at the federal, state, and the insurance company levels. In Pittsburgh, we have AIDS-free Pittsburgh. And, we went to the big health companies, UPMC, University of Pittsburgh Medical Center, and Allegheny Health Network, and we got them to pony up money so that we can do more outreach and we can do more work in ending the epidemic by, getting more people tested and getting people access to PrEP. And then, of course, infiltrating the social networks. And I think there's a lot of groups and there's a lot of people that understand how to do that. But there's a lot of people that don't. And here is where we need to involve the community. And I don't care whether it's an informal or formal network. We need to get to them, to send messages, not only ending the epidemic, and so using peers, community leaders, and influentials. And they are not necessarily health providers. They're people living with HIV. People with the lived experience are central in ending the epidemic. So I'm going to stop there, and I probably talked too long about this, and I don't know whether I entirely answered your question, but these were the things that I wanted to mention in maybe a way of remembering it. So thank you.
Oh, absolutely. And that was excellent. I want to touch more on a point that you brought about stigma. We know that stigma is what is very much still fueling the epidemic. Why do you think after 40 plus years, some of the myths surrounding HIV are still being spread at the rate that they're being spread, and that the misinformation out there, as kind of like what we saw with COVID, the misinformation out there is still being spread, and the myths aren't being debunked? Why do you think that stigma still exists?
Because we have old people like me, and we have young people that were never around when back in the day, when there was no treatment and people were dying. And then there's still a lot of people that don't really understand mental illness, and they don't understand substance use. And they have we think of it as a biomedical disease, and, there's still people out there that, because of how they maybe learned about it or the way they were brought up, sometimes people feel as though, well, if you just, the whole idea of you just pull yourself up by your bootstraps, and, move on. But, in having been in psychiatry for so many years, I know that mental illness and substance use, there's these are brain diseases. And so I think there needs to be a lot more public education about this. The stigma associated with these things, I think people are afraid. People still don't want to talk about it. But I'd like to hear what the rest of the group thinks about this. Why is stigma still there?
Ricardo, would you like
Maybe
or
from
Timothy?
the audience.
Yeah. I would just, as a person living with HIV, stigma is something that is all encompassing. And for whatever reason, over the 40 plus years of the HIV epidemic, America has had and continues to have this fascination with the other. We see it with people who are experiencing homelessness, people who use drugs, and anything that is outside of the model majority. And so it comes from a lack of education, lack of awareness, lack of just knowing how to use people first language. We look at these things as though they are some abstract thing when we are actually talking about people. People living with or impacted by HIV are people. People who are impacted by substance use are people first. People who are impacted by homelessness are people first. And for whatever reason, America's fascination with viewing the least of us through these prisms of homelessness or HIV or substance use or mental health, all of these things, we focus on those things that are so abstract and we may not know about it, as opposed to focusing on people first. People are what matters. And so anytime that I talk about stigma, anytime I talk about HIV policy or harm reduction, I am talking about people first. And I think that is the reason why I make sure that when we talk about our language, the language that we use also perpetrates stigma. So anytime we say HIV infection, I just, it kind of grates on my nerves. We should be saying HIV transmission. That infection word should never be used when you're talking about people. And so, yeah, I think that goes just a long way of really trying to change the narrative around all of these subjects.
I love that. Coming from that viewpoint of people first, I think if everyone were to take that stance, a lot would be different in our world, not with just HIV, but in so many other areas. But I love people first. Absolutely. Ricardo, did you want to jump? I know you are experiencing so much stigma in Texas.
Yeah, very specific to this. I think, I think part of the reason why stigma still lives is because our anti-LGBTQ forces have really been successful at making people believe that this is something that only impacts LGBTQ communities, right? When this does not, like AIDS, HIV does not discriminate based on sexual orientation or gender identity, right? Everyone is at risk, and education should be done to really make sure that everyone has the most information, up-to-date information that could really prevent transmission.
Absolutely. Timothy, has the federal government, including the judiciary, created any barriers to your EHE goals? I see you laughing, so.
Where do I start? I'll start with a decision, the Braidwood decision, that was handed down earlier this year that really could stand in the way if it really upends. And essentially, just for those of y'all that are not familiar with Braidwood decision, it's this district court case that basically the people that came to this case were saying that PrEP is against basically their religious right. And that insurers shouldn't have to cover it. Right now, insurers have to cover PrEP without cost sharing. And so they're basically saying their insurer shouldn't have to cover this because it's against their religious right. they're also challenging the USPSTF, which is the United States Preventative Services Task Force, which basically sets the recommendations for all preventative services under the Affordable Care Act. And so they're basically challenging the legality of the USPSTF. So why does that matter? That matters because if they're successful, not only would PrEP and PEP go away without cost sharing, the insurers have to cover that, so would mammograms, so would regular vaccinations, so would so many other just regular standard of care things that we take for granted, preventative services. And so that is clearly standing in the way of us ending the HIV epidemic, because that means that's prevention, that's care, that's also care for STIs, which we have seen balloon out of this world, record levels, especially among syphilis. And so it's all of those things that really stand in the way of us ending the HIV epidemic. Ending the HIV epidemic is not just ending HIV, it's also ending or bringing to a short close all of the things that impact in HIV. So whether that's discrimination, whether that is stigma, that homelessness, all of those different things. And so, yeah, that case is really kind of my bugaboo right now.
Absolutely. Thank you so much. Any of the other panelists want to add something? I see you smiling, Ricardo. Linda?
Yeah, I just wanted to say, the legislative stuff, I think is really important that Timothy brings up. And so as a clinician, I want to know, what can I do in my practice? And what can I do with my patients? Because a lot of people, we don't have control over what's happening with this legislation and stuff. What can I do on a day-to-day? Access, whatever it is that we're talking about. And I think it also, for me as a clinician, it always meant I got to do my homework. If I want to link somebody to PrEP, I got to know who's doing it, where they're doing it, what their name is, how can I get people to there, who's doing testing, who's doing treatment. I got to know people. It's about relationships in your home community. It's about the relationships in your county, in your region of your state, whatever it happens to be. And also, it involves those relationships calling up your friends and saying, look, I got this person or this family or this situation. Can you help me? We don't have anybody here, but do you have other resources that we could use? And 9 times out of 10, people come up with stuff, and I'm a lot of people think I'm I grew up in the city. I grew up in rural Pennsylvania, right? I grew up in a fishbowl, and what's happening in rural areas is we don't have enough clinicians. And so we have to figure out a way in which we can grow our own. And I think that goes to the issue of how can we get the federal government to pay for loans for students that want to, become a social worker, become a nurse practitioner, become a physician, and, get it paid for, and so that they stay in the rural areas. That's something in terms of workforce development, I think needs a bit more attention. And so I'm just going to leave it there.
I love that. If you're speaking of rural areas, I think it goes back to what Timothy was saying about people first. I think if our elected officials looked at it from a people standpoint, things would be a lot different. So thank you all for that. This next question I want to pose to all three. The end of the HIV epidemic, EHE, the goals are to have a reduction rate of new HIV cases by 75% by 2025 and have a reduction of 90% by 2030. Is this goal attainable? If yes, how so? If no, why not? Whoever wants to go first.
Any one of us?
Any one of you.
Um, I always think that, it's a lofty goal, right? But I think it's meant to be a lofty goal, because there's always this path of possibility, where if everything goes right and everyone is pulling their weight, this is held in trust, right? As long as everyone is contributing and moving in the right direction. But I do think that, I think back to this meeting that I had with the New York City Pandemic Response Institute and AMFAR and the Foundation for AIDS Research. They convened a small gathering of MPOCs, and during MPOCs we were talking about HIV and AIDS, and we started talking about moving towards direct provisions of community funding and non-categorical funding that allows flexibility within spending, right? And then you're empowering communities to really think critically and innovatively about what care looks like in response to each community, right? And communities do play an incredible role in ensuring that we are making strides to ending HIV. And that's so many organizations across Texas that are doing this work and playing a part. So, but that also means promoting greater involvement of community within even the diagnostic tests, in making sure that people know how to use them, how they're simple, preventing user error, right? And ensuring that we're electing people that are not going to use us as a talking point, because there is a fragility when it comes to funding when someone trivializes the funding that we are receiving to take care of people, right? Going back to what Timothy said, this is about taking care of people, and our legacy, we own it, right? Whether or not we want it. And we let a whole generation of LGBTQ people die. And I don't necessarily think that people understand that that is part of what we owe it to our community, our legacy moving forward. And then just I would just say again, ensuring that we make things available in a way that people can digest and internalize, right? So we can use ads, digital ads, to get the word out. We get to meet people where they're at, right? One of the innovative things that I see here happening in Texas is these vans that are going to the clubs, right? And it might not be the sexiest place to get tested, but it's necessary, right? And that's where people are going to trust. Bars have always played a central place for LGBTQ advocacy and resources to be made available, and collaboration across organizations, one, equality organizations that take care of everybody, but organizations that are specifically focused around Black and brown queer people, and bringing us all together to the table so that we're providing resources in a way that all of our different constituencies communicate, because we are not a monolith. And we have so many different ways to communicate, receive, and internalize information, and we need it from a trusted source.
Absolutely, that was some good stuff. So let me just, before the other two panelists jump in, let me ask a follow-up question. Being in Texas, and you stated earlier not having the elected officials that are pushing for or that are supportive of things that matter to queer people, how hard do you think it's going to be in Texas specifically to get to that end goal of 90% by 2030?
That's why I remained cautiously optimistic, right? Because I think that you have some political realities within the scope of this goal, right? And yes, it's more difficult for us, but you have to think about, we have organizations like the AIDS Healthcare Foundation, PRISM North Texas, Abounding Prosperity, Legacy Community. There are so many in Texas that are doing the work without the help of government in terms of just the sheer amount of response and urgency that you need from a state, right? But we do have the federal government who is providing streams of funding that help, But ultimately, we are at a disadvantage to a certain degree. But you have to understand, this is the thing that I tell people all the time. Our community has never really, at least in Texas, ever had institutional power. We still don't have institutional power, but we do have the power of the people. And 75% of Texans believe that discrimination against LGBTQ people is wrong. When people say that we are a small community, they are wrong, because every single one of us has a handful of people who love us, if not 2 handfuls, 3 handfuls, or 4 handfuls, right? So our community is not solely the 1.8 million LGBTQ identified people here in Texas. It is times that by 10 or 15 or 20 of the people that actually care about us. And so, yes, it's going to be difficult, but that doesn't necessarily mean it's impossible.
Absolutely. Thank you. Want to hear from the others?
I just wanted to add one other thing, if I could.
Absolutely.
About the 2030 goal. One of the areas of concern has been PrEP for women, and which has not gotten as much attention. It's getting more attention now, but we do have to think about that, because there are a lot of women, particularly minority women, who are getting HIV infected, but there's women getting infected all the time from their partners or from their own sharing of syringes. So we have to think about that population as well. And also our youth, people that are in charge of kids in high school, getting to our college campuses. I know that some of those things are happening, but we need more efforts there, because
I think we lost you, Linda.
You know, an ounce of prevention is worth a pound of cure. Now, no.
Yes, we hear you now.
Okay, but we've got to get those folks access to PrEP, and there's this whole issue now of can you give minors PrEP, and I think that varies from state to state, and that's not something we're going to get into today. But I do think that that's got to be on the radar screen, if we want to get ahead of this. So I'll stop there.
Absolutely. You brought up a great point when in regards to women on PrEP. I think part of that also has to go into the education of the providers. I've heard personally from individuals that are working in infectious disease say that they did not know that that women could also use PrEP. So we need more education for not only the general public, but providers as well. Timothy, I'll let you jump in with the goal of 90% by 2030.
Yes, the policy nerd in me says yes, we can. The person living with HIV is, to borrow Ricardo's terminology, cautiously optimistic. And that's being as real as I can be. But I think I am a solutions-oriented person, and how do we get there? One of which is something that I talked to a number of organizations and clinics here in Illinois, and when I lived in the South as well, is no wrong door approach. People that come to our clinics, they don't know that you're supposed to go here for this, here for this, here for that. It takes just a moment for you to link someone. If they come to the wrong clinic, it takes a few moments for you just to link them to someone at another clinic. But we oftentimes don't take that extra step, and people leave these clinics disillusioned or upset because it seems like no one cares about them, when all it took was for you to just pick up a phone call and say, hey, I'm going to connect you with this nurse practitioner or this case manager or something to make, that. So no wrong door approach is something that is huge for me. 2, understanding trauma-informed care is a thing. And we should be making that central to the care that our communities are receiving in our clinics. Understanding that they come to these appointments with all of the trauma, the hurt, all of the things that, the stigma, whether that is self stigma or externalized stigma, understanding all of these things. And so understanding that as Ricardo said earlier, we're not a monolith. And understanding that each one of us has a story. I'm going to go back to what I've been saying this entire call: people first. Understanding that we need to recognize the beauty of humanity, of the communities that we serve, and understanding that at the very least, each of us has an opportunity and a responsibility to snuff out stigma at every turn. That is what is going to get us to meet those goals of ending the HIV epidemic. Anything less than that, we are going to be here another 20, 30 years. And that is being honest. And I'm going to follow that up with saying, you do that by centering community, centering people living with HIV, people that are impacted by homelessness, people that are impacted by, substance use, the LGBTQ community, specifically our transgender expansive communities, making sure that, again, we are not a monolith and that we have to be specific in our outreach to these communities. So I could get on the soapbox all day, y'all. I'm gonna try my best to be good.
I know it's good stuff. Good stuff. Yeah. And I love that you brought up trauma-informed care. I think that is so integral and so important to the conversation when we talk about ending the epidemic, because there are so many people who have experienced and are experiencing trauma in so many different areas of their life. So I'm so glad you touched on that. So we've talked a lot about barriers and stigma and everything. What are the most urgent, or what is the most urgent barrier to the EHE goal that needs to be addressed?
Oh, that's an easy one. Besides stigma, is what are we doing for our long-term survivors and our older adults living with HIV? And the reason why I say that, right now, over half of people living with HIV are over the age of 50. By 2030, that number is estimated to be 70%, which is great that we think about, because 20 years ago, that was not even a possibility. And so that's being completely honest and real and upfront. But what are we going to do about this population that is going to continue to get larger? Are we putting things into place right now, policies, whether that be the EHE plan, whether that be state or local plans to address LGBTQ older adults living with HIV, long-term survivors? We understand they deal with isolation, depression, having to go back into the closet when they're in long-term care. All of these things matter. And again, we can't end the HIV epidemic without ending all and addressing all of these other issues as well. And so I think that is one of the things that are top of mind for me.
You are preaching. I agree with everything you just said. Linda or Ricardo?
I'm sorry, I got kicked off. What was the question?
So we have been talking about barriers and stigma. What do you feel like is the most urgent barrier to the EHE goal that needs to be addressed?
Okay. Well, I think I said earlier that I think it is addressing stigma. It's getting the money that we need for the services. It's providing supports, and it's supports for people living with HIV of all. Doesn't matter how you got it. As we've been saying all along, it's about people, but what kind of supports can be tailored for them that make the difference for them, because it is not one size fits all for support services. We also need to support our healthcare providers. We expect them to do a lot of things. A lot of them are not in the know, and we've got to get them in the know. We still have people who really continue to question U equals U. And we've got to do more education of healthcare providers about the fact that treatment is prevention and that PrEP does work. And, that message has to be loud and clear and disseminated. And I think we have to do it, we can do it one-on-one, but we have to get to national organizations, the AMA, ANA, the national, whatever national groups there are, we've got to get to them, and we've got to get on their agenda to talk about it. And then of course, the social networks issue of using, influentials, people living with HIV, people with a lived experience, whether that be HIV, substance use, mental illness, to really talk to others and to work, at the organizational level, at a systems level, or at a community level, or the one-on-one. And I think that we can learn a lot from international work in HIV because they have picked up a long time ago on the fact that they don't have a lot of providers. So they have to use a lot more, peer educators and, community folk, to get the message out and to link people to care. And the point about the aging population in HIV, I'm old enough that back in the day when people were dying right and left from HIV because we had no treatment, in Pittsburgh, we put together a nursing home that was specifically for people with HIV. It got closed after we started giving triple combination therapy because people were, living longer, and the mortality rate in 1996 dropped by 50%. Now we're faced with the same issue because of people aging up and needing nursing home care and long-term care. So we've got to get to those people as well, the people that are running these long-term care facilities and the people that work there. And oh, by the way, we have to begin to pay people more money to provide services. The long-term care folks that work in these facilities, their salaries are abominable. They get paid very little. We've got to do more about getting people to be paid in such a way that we attract people to work in these facilities that are going to provide quality care. And that's another entire conversation, but it's something that we really do have to address.
Absolutely. I totally agree with that. Thank you. Ricardo, I know you have to step out soon, so let me ask you this question. And Linda touched on it with community members. What are some ways that the general public can help in the epidemic?
Let me just add one thing to the last thing we were talking about, because I do think that if we, and then I'll get to your question. I think in order for us to be successful at really getting to our goal and ending HIV/AIDS, I think part of it is also addressing the risk factors that people have, right? It's not, this is not it, right? Prevention is just part of the goal, but we have to begin to address like what gets people to experience these risk factors, like secure and safe housing, quality education. There's so many things that throughout someone's life, we can start taking actions that contribute to the goal, the overall goal of ending HIV/AIDS. What can a community do to help end the epidemic? I think number one is, we have a low capacity to have difficult conversations, right? And to have empathy and compassion with ourselves and also with community members. I think having honest conversations with our partners about our status, not necessarily leaving it on people with lived experience to explain HIV/AIDS to you, and how being having a low viral load equals non-transmission, right? Like you do your own homework, right? You have to do your own research. You have to stay up on the know, but you also have to have honest conversations with your partners. Being safe, as safe as you possibly can, right? PrEP is a method of doing it, but also continuing safe sex practices, which includes using whatever keeps you safe, right? And educating yourself on things like DoxyPEP, and being able to know what is available to you so that you can keep yourself as safe as possible while still expressing yourself boldly and unapologetically. I think all those ways are important. And then on the stigma side, it really is continuing to reach different communities right where they're at, and providing information in a way that can be understood, maybe simplified, and so people can take action. It feels actionable, right? It doesn't feel hopeless.
Absolutely. Thank you. And I know you have to drop off soon, so I want to tell you thank you so much for being a part of this conversation. Your insight has been invaluable, so thank you so much. And to Timothy, I ask you the same question. What can the community do to help end the epidemic?
I thank you for the question. And the way that I'm going to answer this question, I want to speak directly to people living with HIV. I need for you to speak up. And whether that is for whatever that means to you, let me say it that way. Whether that is in the doctor's office, I need for you to be a hell of an advocate. Because we can depend on doctors and other providers and all of that. But when we understand the Denver principles, that we are people living with HIV, that we are the subject matter experts. And so we control our lives. And so whether you are in a doctor's appointment, I need for you to be an advocate. Whether you are on social media, if you're able to do that and you see erroneous information, misinformation about HIV or anything related to it, push back on it. If you can't do it, find someone who can. If you have an ability to attend conferences or participate in your local Ryan White planning councils, do it. Because there are so many times where I am tired of being the only person living with HIV in rooms where decisions are being made for people living with HIV. And so what I need for you all to do is I need for you to help me. Partner with me, whether that is in Texas, whether that is in Pennsylvania, West Virginia, Mississippi, or Alabama, where I am from. It doesn't matter. So I need you to partner with me and other people living with HIV in order to continue to do this work, because ultimately, all of ending the HIV epidemic matters to us. It impacts our lives day to day. And so that's what I would say that the community can do to help end the HIV epidemic.
Excellent. Thank you. Linda, what would you say to the community asking what they can do to help end the epidemic?
Well, first of all, I think people in the community need to understand their community. They need to know what the issues are. So you need to ask people, what are the issues? What are the barriers? A lot of people, they're not thinking about HIV because they don't have a place to live. They don't have enough food. So you've got to look at the social determinants of health. As a public health professional, we've got to look at that. And I think that's what a lot of people were talking about before. So you got to get the community's input. You have to identify what are priorities for them. We can't do everything all at once, but what are the priorities? We have to build bridges between organizations between peoples and between agencies and programs. And we have to increase communication and coordination around services and funding that's already on the table, and help to identify what additional funding is needed and go after it, doing advocacy with local government, state government, and the federal government. And finally, as a card-carrying nurse, I really think that we have to do our homework. If we want, to figure out what to do, we have to really understand it. And, and there's so many things to understand. When you think about how many articles come out every day on HIV and substance use and mental illness, it's overwhelming. It's impossible, really, even for people who are just doing that, to keep up with all of the changes and the nuances and the new things that are happening. And so we need to depend upon our fellow colleagues to keep us in the know, and communicate that and disseminate that to our community. So that's what I would say about, how do we do that?
Absolutely. Now, I love that you stated that we need to do our homework. That is so true. In order to not only educate ourselves, but to the members of the community, and when all the misinformation and all the myths that are out there. So thank you for that. I know we are coming down to the wire. I wanted to leave some time for questions. Let me see. There's a lot in the chat. Midge, am I supposed to look in the chat or the Q&A? Let's see here. I don't see anything in the Q&A.
No, there is nothing in the Q&A, but there is another question that has come up that will take us through a few more minutes.
Okay.
And this question is specifically for Timothy. The question is, are there some questions that haven't been asked today that you could speak into with regard to your experience or your knowledge? And likewise for Linda.
Yeah, I would say one of the things, what are the things that shocking to me that didn't come up was really kind of a conversation around harm reduction. I know Linda kind of mentioned kind of West Virginia and the HIV outbreaks that have occurred there. Obviously, we need to be talking about harm reduction, whether that is through supervised consumption sites, whether that is through syringe service programs. So that's something that was interesting that didn't come up. We need to have a conversation around STIs, and really kind of how do we right size our healthcare delivery system in a post-COVID world, right? We understand that during COVID, much of the HIV care delivery system kind of put HIV on the back burner so they could address COVID. And then you have Mpox that comes up. And so how do you still address HIV, Mpox, the rising rates of STIs, and COVID, all using the same people that are burnt out and overworked? And that is something that I think we need to address. I know we are seeing that here in Illinois with vacancies that are through the roof, that you can't find enough providers, you can't find enough nurses or nurse practitioners or case managers. And so how do you continue to progress ending the HIV epidemic without those care professionals? And so, yeah, all of those things, I think we did a great job talking about stigma, talking about community, talking about kind of some of the high level things. One of the things that also shocking that didn't come up is this conversation around a national PrEP program. I know that Congress is considering, I know President Biden has included it in back-to-back years of his budget. And so where does that go from here? And then finally, HIV criminalization is something that is kind of their that impacts people living with or vulnerable to HIV. And we know that it stands in the way of ending the HIV epidemic and getting people tested as well. So all of those things, again, we don't have enough time in the day to address everything, as Linda mentioned. But yeah, those are some of the things that I would have liked to have highlighted. Yeah.
Thank you. Linda, did you want to chime in?
Yeah, I mean, I agree with everything that Timothy has just said, but there's another population that I've spent a lot of time working with, and those are people, incarcerated populations. And how do you make that transition for them out of correctional settings back into the community and get the services that they need? We have a large population of people in our jails and prisons that do have HIV. Most of them got it before they went into jails or prisons. And so it links into the social determinants of health. And how do you get people back into the system and the networks? It's very complicated sometimes for people. It seems easy for us because we do it all the time, but it's confusing. When you've been out of the system for a while, and how do you get back in to get the services that you need? That's sort of troubling. And then again, I just want to make mention of the need for services for women. And it's not just women, it's families. And we have to think about, as we've been talking about all along, it's about people, but it's also about families, whether it's your family of origin or your family of choice, whatever you happen to define as family, we've got to get them involved. That's something that, I think a psychoeducational model of using education, not just for the person who has whatever the issue is, but for the people that surround them, whoever they are. So I'll leave it there.
I love that. You know what, we could talk all day and more than a day, probably, about the things that we can do to end the epidemic. I want to thank Timothy and Linda so much, and Ricardo, for being a part of the panel, and for you all allowing me the opportunity to moderate. Thank Caraco. And with that said, I am going to turn it back over to Midge.
Thank you so much, Jaziel, and thank you so much to our panelists. This was a wonderful conversation.